and cope with that situation. Throughout the treatment, you're trying to help the client learn a fundamental belief, which is if I try active coping, I can make my life better. No matter what happens, I can cope without using substances or any other unsafe behavior. And so keep helping the client learn to understand what methods did they try, what worked, what didn't work. In terms of adapting the model, there are a whole variety of settings where one might implement it, a whole variety of settings where clients have trauma and addiction, working with adolescents, working in criminal justice populations, working with HIV-positive clients, working with gays, lesbians, transgendered, and bisexual clients, working with women, and so on. Couple principles if you're going to use the model and you're trying to adapt it for your population. The idea is, first of all, try it as planned. Don't assume on the front end that you need to adapt it or should adapt it before you've tried it out, because the idea is to learn from clients directly, to try it and see what happens. And what you'll find is clients will give a variety of responses, and the modifications, if any, will happen based on how they're reacting. There are two methods, essentially, of collecting information from the client about their feedback about the model. There's an end-of-session questionnaire that they fill out at the end of each session, and they can comment on positive and negative impressions, what they would like to have differently in the model. There's an end-of-treatment questionnaire where they can fill out what topics were most and least helpful to them. What did they like and dislike? What aspects of the format worked or didn't work for them? And at the end of every session, they're going to tell you one thing they got out of the session. So there are multiple ways of hearing their responses to it. The idea throughout is always to use examples from their lives. You know your clients, you know what issues and problems are important to them. And so making sure to use examples that are relevant for them, whether based on ethnic diversity, gender, age, or any other characteristics that make your population unique in their needs. Often what you'll see also in programs is a bottom-up conversion, that clients essentially may influence the adoption of the model, that if clients like the treatment, a broader array of clinicians may come to implement it, and administrators may come to see it as valuable. But the idea, again, is always learn from clients how they're responding to it. In terms of diversity, it's very important to take into account differences in populations, whether based on ethnic differences, racial differences, age differences, gender, and so on.
Well, actually, another part of the traumatic experience for me as a woman and as an African American woman has been just also like in school, people expecting less of you in the sense where, you know, if you're in advanced classes, they making comments like, well, you're here only because, you know, you're an African American or you're a token, so to speak.
Seeking safety has been implemented in a variety of diverse settings. To name just a couple of studies, in the Hien study on low-income urban women, 77% were minority, including 50% African American and 24% Hispanic. In the study by Zlotnick and colleagues in a prison setting, 35% were minority, including 11% African American and 6% Hispanic. And in the original pilot study on the treatment, 12% were minority, all African American in that case.
The prison population is pretty diverse, pretty ethnically diverse. For the most part in our program, we've had primarily white, Hispanic, African American, women of all different ages, anywhere from 18 right on up to in their 50s. So, and they all have responded equally positively, I think, to the treatment.
Some frequently asked questions. Do clients have to have a formal diagnosis of PTSD and substance use disorder? Certainly it was developed in research studies and tested when clients had these formal diagnoses. In actual frontline treatment programs, they may not have both disorders. They may have, for example, a history of trauma, but be sub-threshold on PTSD. They may have a history of substance abuse, but not have used now for a while, but are struggling with trauma-related symptoms. So it's very common for clients to have one or the other, and to go ahead and focus on the coping skills.
Some of our clients did not have a formal PTSD diagnosis. They, in almost every case, had trauma histories, which we, as part of our intake assessment of all clients in the clinic, measured. So we knew that pretty much all of the clients that had been referred to the groups had trauma histories. However, again, a number of them didn't have the diagnoses.
With all the handouts, how do I select what to focus on? The goal typically is to prioritize any unsafe behavior a client reported at check-in. The check-in is like almost a thermometer, a temperature check. How is this person doing today? And if the client has reported unsafe behavior, the goal is to try and come back to that to the extent you can in the course of working on the topic. Go where the client goes. Have clients scan handouts and ask them questions such as, what strikes you? What would you like to focus on? Really let them take the lead in figuring out what they need to address. Should the client join Seeking Safety only after an initial stabilization period? Because the model was designed for use from the very start of treatment and for all types of treatment settings, for example, inpatient, residential, outpatient, and so on, there really isn't a need to stabilize the client first. In fact, the very goal of Seeking Safety is to help stabilize the client, to help them attain safety. What if a client brings up trauma details during the session? And this will happen. Even a topic that may not seem to trigger can evoke intense feelings or memories for the client. You may be covering the topic, taking good care of yourself, and it may remind them that when they were growing up, they suffered severe neglect by people in the family, or so on. And if they start telling details of it, typically you're going to want to redirect them kindly and supportively. For example, the client may start saying, well, I remember growing up when I started to get beaten when I was about 6, and my father would come into the room. You might say at that point, let me stop you there. What you're saying is extremely important. However, right now, it may not be safe for people in the room to hear what you're talking about. It may trigger other people, and it may not even be safe for you. And so I'm going to ask you, if you don't mind, to tell us about the issue, but talk about it to the extent you can of how it's playing out for you in the present. Now, it's not to say that clients can't ever mention their trauma. In fact, it often is part of the session on PTSD to have clients name the kind of trauma that they experienced. I suffered child abuse. I was raped. I lived through domestic violence for 10 years. I suffered in combat. Whatever the trauma may have been can be named in a short phrase or a sentence. But the idea is to avoid graphic details of it that might trigger them. Also, you can explain that the group needs to stay safe for everyone and that trauma details can be triggering. You may also want to describe readiness for trauma processing, that they may need to focus on goals such as stopping the substance use, stopping self-harm behavior such as cutting and burning, ability to retain some sort of consistent attendance at treatment. Any sort of key goals you have for them can be used as leverage. Once we work on that, then it may be a better time for you to go into the trauma details. How to select clients for the treatment. In general, it's hard to identify characteristics on the front end to define who is going to succeed and who won't succeed at a treatment like this. And so the idea is to be as inclusive as possible. Allow all clients in, and then if a problem occurs, at that point you may need to remove the client from the treatment, or if it's a group, from the group. So typically you'll you might say to the client, you can try out this treatment. You don't have to commit to it. You don't have to say you'll attend X number of sessions. You can try it out for a couple sessions, see how it feels to you. Some clients may be scared of the idea of doing any treatment that has any focus on trauma. And so let them try it out, see how they like it. Also, select clients who want to be in the treatment. It really goes against the nature of trauma treatment to require a client to do PTSD-focused treatment. The idea always in PTSD work is empowerment, letting the client learn to take control, because control was so taken from them by nature of the trauma. And so the idea is, do you want to attend? Try and encourage them, but try not to force them to attend. Are there particular issues for group treatment? You may want to avoid names such as trauma group or PTSD group. Clients may assume that you're going to be discussing traumas in detail. Rather, try and take some name that may feel more optimistic for them. Seeking safety group, or coping skills group. Plan the number of clients based on session length, remembering that the check-in can be up to 5 minutes per client. That is one aspect that you may choose to modify if you have a very large treatment. For example, some people run groups of 30 clients in a session, and you may have to cut down the check-in and conditions like that. However, in general, assume that the check-in will take several minutes per client. So you may want, typically, if you can, 8 to 12 clients in a group. And try and limit the number of clients who may over-dominate or have symptoms of some other disorder that may tend to distract clients, such as a client who's extremely manic and hasn't taken their medications, or any client who has had unsafe behavior that's harmful to the group if they've tried to sell drugs to other people in the group. There may be occasionally times when you'll need to remove them from it if they're doing behaviors that really impair either the staff or the clients from doing the work.
The whole world has opened up to me now, you know. I no longer walk into a room full of people and feel inferior. You know, I'm okay with myself. And there's so many things out there that I didn't see before because of this haze of emotions. I mean, I couldn't even identify what it was I was feeling. I just had these emotions driving me. The sky's the limit. Now, absolutely, sky's the limit as far as my life is concerned, and it's the little things in life that mean a lot to me now.
I don't really think about the past anymore. Not to like forget where I came from, but I don't drudge like, oh, I had it so terrible, and if you had my life, you'd drink too. That was my old standby. You drink too. But now I just realize that I can live like a normal person and not have to drink. I can go out and have fun and just like everybody else, and I don't know, it kind of feels good. It's kind of like exciting. It's like every day is kind of like the first day of school. Like, kind of nervous but exciting at the same time.
I was just scared, quiet, didn't talk to nobody, didn't say nothing. I didn't think I had an opinion. I didn't have an opinion. I didn't have a choice. And now I'm just like, I'm learning that I do have a voice. I do matter. I have things that I like to do. I can have fun without being drunk. And I can have fun with my children and know who I am. Know that I'm a good person.
Thank you very much for being here today, and I really wish you the best in your continued work with clients. Any questions that anyone has?
When working with clients in a group setting, how do you handle situations when clients become very emotional or get very upset during the session?
That is probably one of the most essential questions, because the nature of both PTSD and substance abuse is that clients often experience very intense emotions very rapidly. And so it's key to learn how to help them learn to contain it, but to do it in a way that's very kind and supportive. For example, a client who's very angry, you might say to them, I really hear that you're very upset right now and very angry, and there's very good reason for you to be upset. Now, you don't have to agree with the client about what they're complaining about or concerned about, but you can just say, you know, I'm sure there's something here that eventually we can work through. But right now, it may not be helpful to try and go into it while you're in this high level of intense emotion. And if you remember, one of the goals of treatment is to help to learn to reduce that kind of intense emotion. And so if it's okay with you, what I'm going to ask you is whether there's a way, whether using grounding or just kind of sitting quietly for a little while, you can kind of come down to a lower level. For example, on a 0 to 10 scale, 10 being the most intense, 0 being not at all, maybe down to 5 or below. And if you want to talk after the session, we can either schedule a time or find a way to be able to address what the issue is. So sometimes what you'll want to do is delay the issue or address it in some very small way now that's not going to get into a combative situation, or typically if clients are very emotional, they're not going to be able to see your point of view at that point.
What are some strategies that you would offer to new clinicians beginning the CPST safety treatment?
That's a really important consideration, because new clinicians often need a lot of support, even if they're very experienced and skilled at doing other models. They may not be used, for example, to working on both PTSD and substance abuse at the same time. They may not be familiar with the case management strategies that can be helpful as part of this treatment, and so on. And so there are a variety of things that can help the person feel supported in that initial learning curve. First, really try and give them some guidance on the front end. Sometimes when people see the book, it's very long, it can look overwhelming. Really help break it down. Typically, I'll suggest to clinicians, just read chapters 1 and 2, which is background about the disorders and the treatment, and then how to run the session. And then pick one topic. For example, a simple one, the shortest one in the book is asking for help. Take that one perhaps. Read it through and just try it out. See how it goes in the session. See how clients respond to it. See what it feels like for you. Second, to the extent that you can provide them with support as they're learning the model, in other words, supervision, whether it's peer supervision or any other kind, other people who have done it, learning from what has worked for other people, what hasn't worked for other people in terms of learning it, can really be helpful, because for example, the clinician who has never run a manual-based treatment before may feel uncomfortable with using a format. Just helping them get some feedback about that, or some reality testing. Yeah, it feels awkward at first. It may not feel comfortable. You may feel like you're cutting the client off, whatever it might be. Finally, make sure that in the beginning, the clinician is collecting end-of-session questionnaire information from the clients. That's a one-page form that's in Chapter 2 of the manual. And at the end of every session, the idea is to hand that to every client, if it's a group, or to the individual, if it's being run in individual treatment. And the client fills it out. And it basically expresses positive and negative responses to the treatment session and what their rating scale is, from 0 to 4, how helpful was the session, the topic, and the therapist, for example. Very quick, but what it does is it gives them repeated feedback about what's working and what isn't.
My question is, could groups be co-led? And if so, what's the best way to use the resources of those two leaders?
Co-leading groups is a wonderful thing to do if the program has the resources to do it. There are many programs where they can't have 2 leaders in a particular group. And so when I originally developed Seeking Safety, I first tested it in my pilot study using a single leader, because that was typical of a lot of programs. However, Co-leading, many people say, actually feels better for them, feels safer for the clients. It allows one clinician, for example, to make sure they're always tracking the room. The other one might focus, for example, more on working with some of the material or the handouts, but certainly sharing the responsibilities that are so diverse in running any group session with clients who may have so many different needs. And so co-leading is wonderful if it's a possibility, but it certainly can also be done as a singly led model.
Does a clinician need any particular degree or training or any particular area of expertise to conduct this treatment?
At this point, I have never yet seen that there's any particular degree or training that makes someone either very good at doing this model or very poor at doing this model. The characteristics I have seen that matter are things like a real willingness and interest in working with this population, really liking these clients for who they are and what they've struggled with. Also, people who are willing to get cross-trained if their background isn't in substance abuse, to really learn that area of work. If their background isn't PTSD or mental health, to be willing to learn, to read, to go to trainings and so forth. So cross-training is always one of the key topics in working with any dual diagnosis. However, characteristics such as experience level, type of degree, whether it's a PhD or a bachelor's level degree or a master's degree, gender of the clinician, and so forth. Those characteristics actually have not been found related to outcome in general in the psychotherapy and counseling field. So there seem to be some more subtle processes where the clinicians who are good at this work may have some other set of characteristics. And certainly if a clinician does not want to do this kind of work, some clinicians don't like manual-based treatments. They don't want to use handouts. They don't want to follow a format. Maybe those are people who really don't necessarily have to. Certain amount of that can be sometimes worked with in terms of training or having them try it out, but really if after trying it out they feel like this isn't the kind of treatment I want to do, maybe they shouldn't have to do that.
You said to try and be as inclusive as possible when inviting clients to join the treatment. What about patients who may also have dissociative identity disorder and could possibly be actively dissociating during the treatment?
That's an excellent question, because in this population, some number of clients will have dissociative identity disorder. And what we typically have found is that some of them can attend the treatment and do just fine, and that the focus on coping skills actually helps reinforce their ability to stay contained, to integrate, to focus on functioning in the present. Typically, you would sort that out with the clinician who is treating them individually. And usually those clients are of such severity, if they do have full-blown dissociative identity disorder, that you would definitely want them in individual treatment. What you'll find is that some clients may respond especially well, for example, to two key things in the treatment. Grounding, that when you see that they're dissociating, just as you would for any other client who's dissociating, what you would want to do is pause what you are doing, take a few moments, and help ground the person, help make sure they're still with you, still present. You might say, you know, you look as though you might be dissociating. Is that going on for you right now? And the client typically will be able to answer that. Yes, I'm kind of zoning out in my mind. I'm not really here. Would you be willing to do some grounding right now for a few moments? And then walk the client through it out loud, having the other clients stay silent but follow along so that they stay grounded as well. And the client typically will be able to come back to the present and stay in the session. Another key process in working with clients who have DID is to focus on containment and integration, not going to look at who the different alters are or have them describe the different alters' experiences, which can be very destabilizing for the client. The goal is to always keep the host personality, that is the main ego, the main person, the one that goes by their regular name, in the room. And so sometimes, for example, a client may say, we had a client like this in one of our groups, at the check-in when she was asked about any substance use or other unsafe behavior, she would say, the big one used. I'm the little one, but the big one used. And we would say, you know, it's really important that you be conscious of your use during the week and take responsibility for that, because it still is you that's using. And we need to work in the treatment with you, with the main person. And so in a gentle way to remind them that the goals are containment and integration, and that the work on exploring alters happens only in individual treatment and only with someone highly trained to treat that disorder.
I'd like to ask if there's any advice you can provide in dealing with termination. As an agency, we've gone through several cycles now of seeking safety and have terminated several groups. And a number of the clients have had difficulty with that process despite our best efforts and in following the recommendations in the text.
In general, your experience is one that I've seen in other programs and have directly seen in client groups that I've worked with, which is that sometimes a time-limited model may feel like it's not enough. The client may feel at the end, even if you do all 25 topics, even if you do it spaced out over quite a long number of months, the client may end up feeling that they don't want to end. And I think it speaks to their connection to you as the clinician, certainly, the program. It's really is a wonderful thing in a way to know that the client got so connected that it's hard for them to leave. However, there is a point where they'll need to leave due to resources, due to moving away, due to the group ending, whatever the cause might be. And so what can be helpful are a couple of strategies. First of all, what you would do in any therapy, which is be clear with the client from the front end what the termination will be so that it's not a surprise to them. If you're going to do 12 sessions, for example, some programs just pick 12 and do that. Help them know that from the beginning and remind them of that. If you need to at every session. We're now at session 6 and we have 6 more to go. Just helping the client stay aware of that reality can be useful. In some settings, it can actually help to hear those struggles as feedback, and it may be worth extending the treatment if that's at all feasible. I know that when I've run it as just one topic per session, clients would say, we'd really rather have 2 sessions per topic. If we're doing setting boundaries in relationships, it feels too short to cover that in one session. And so what I've moved to when I've done it, for example, on an outpatient basis, is to allow clients 2 sessions to go into a particular topic. So sometimes you can elongate the treatment. Sometimes helping them to interpret their difficulty in relation to the disorders. Why might it be hard to terminate if you have a history of trauma and PTSD? It could be because relationships for you have been fraught with leavings, with abandonment, with betrayals, or it's been hard to connect with people and feel safe, and so you don't want to leave it when you do experience it. And helping them in general, whenever something difficult comes up in the treatment, if you can help them interpret it in light of the PTSD. For example, if a client isn't doing a commitment and they persist in not doing their commitments between sessions, you might say, many people with PTSD find it hard to follow through on things. They may feel hopeless. They may feel like it's not worth trying in life. That's very common to feel demoralized. So you help them interpret their experience or behavior in a way that hopefully will be validating. Similarly, around the substance abuse. For some clients, it may be that this was a way that they could